You'll answer on your phone, okay? On your
But I
phone.
see Graham and my name right now.
All right, so let's see. We're about to start. 1, 2, 3, go. Everyone, good luck. All right, so lithium was here for a distraction, a very strong distraction, right? And then we kind of mentioned this in the last 2 days, that lithium is the medication of choice. No doubts about that. But if someone is manic right now, it should not be necessarily your priority right here, right now, right? So prescribing a low dose of olanzapine can bring the mania down, and then you switch to lithium, right? So it's like a rapid relief. And in fact, I like to do my treatments with a mood stabilizer and the antipsychotics anyways, right? So in the community settings, if you need to take control and send the patient home, or even maybe being admitted for 1 or 2 days, starting with an antipsychotics is your best bet. If you do lithium, you may have to keep the patient for a few weeks, right? All right. Next question. All right, got 5 seconds. Pick your best answer. All right, so we kind of hopped that on a lot. We talked about that it needs to be in 2 different settings, right? So it's part of the criteria. What else part of the criteria? It must have presented with the symptoms before age of 12. And then I gave you an example. If someone, an adult, shows up and says, I think I have ADHD, and seems to be forgetful or inability to pay attention, but they did not have ADHD symptoms growing up as a child, then what you need to do, you need to assess for something else. And in terms of ADHD, 2 settings, multiple settings, at home and in school, is part of the criteria. Very strong. Okay. I don't remember what an A was, but it says as a distractor here. It's true that symptoms must be more than 1 point, one point, but there are not enough for that diagnosis in terms of one settings. Okay. All right. Next question. All right, we got 5 seconds. All right. So hyperactivation or hypofunctioning of the prefrontal cortex, right? And remember dorsolateral and the orbital frontal. You need to know the difference between inattention, the dorsolateral, and the orbital frontal for impulsivity, right? I think it was someone mentioned earlier today in an email, Dory, to help. It was Dr. Lynette. She said, Dory, to help you remember about the dorsolateral for
she has a dorsal fin, lateral fin, and she forgot everything. So that's how I'm going to remember it.
There you go. Inattention, right? You got to come up with a good one for impulsivity.
Yeah, that's the other one.
All right.
Orbital one.
All right. So even if you didn't know anything about psychiatry, it's easy to see that the red and the green says the same thing, right? Methylphenidates decrease tic disorder, and the green stimulants may improve tics, right? Meaning gets better, which both are incorrect. And we kind of hopped on a lot on the class yesterday, a lot, that if someone doesn't matter how well the treatment is, doesn't matter how well they improved for the board, you should not continue the prescription, you should not decrease the dose, you should not change to another stimulant if someone presents with tic disorder. So what are the medication of choice? Clonidine or guanfacine. Okay. In this scenario, atomoxetine can help ADHD, but it's not necessarily the best choice or safer or better than guanfacine or clonidine. Okay. And that's a very important point. You will see it again. All right, you got 3 seconds. Go. All right, perfect. I think pretty much the only therapy is A, right? So I'm sure everyone else kind of picked the wrong. If anyone else picked the incorrect answer was by mistake, that it's okay. It happens. Sometimes being fast with the fingers can happen, right? But yes, cognitive behavior therapy can be very helpful for those with ADHD. So specifically, when you look at the behavior portion of it, what is the behavior? Meaning changing the maladaptive behavior, right? For example, if you lose your car key every day, you leave in the house and you're rushing, well, what would be a behavior therapy portion to fix that? Putting your key, making a conscious decision every single day when you come in, put in a key holder. And you have to practice because you might be putting it in your pocket all over the house and you're always going to find it hard to find your key. So that is what helps ADHD kids and adults. Behavioral modification, right? If you know that you don't pay attention and you have hard time, then making that be a mindful option for you to always do behavior training to improve what is not working. Bite-size content is why we do videos this small. All right, 2 seconds and go. All right, so the question asks, what is the non-pharmacological treatment of a choice, right? A says ECT is one of the most important therapies to begin with. That's not a therapy, right? And then hospitalization, not a good choice either, right? How about antipsychotic, pharmacological, just to ease the mood, ease in control, ease their mood in control. Again, we're looking for non-pharmacological intervention for borderline personality disorder. We know DBT. We know what is the goal of DBT: to decrease crisis, invalidation, self-harming behavior. And we need to know Marshall Lineham. Okay. So DBT is very powerful, but it's very controlled. And you actually need that way because imagine having 14 borderline patients in a group, right? Can be very stressful. So they utilize mindfulness, distress tolerance, uh, everything. There is a time and a place. And even after like the whole protocol of DBT, it is part of the protocol that the therapist will get therapy. This is written into the protocol. So, but very effective in managing borderline personality disorder. Right, this was a little bit hard specifically because the acronym wasn't showing up here, right? But the prompt of the question said avoiding social interactions, right? So that is high yield for avoidance personality disorder. They basically they don't want to deal with that, and they'll make the effort to avoid confrontations or feeling discomfort, right? Avoidant personality disorder. So in this case, the issue is sensitivity to rejection, and the scenario wants to be, avoiding, or individuals with avoidance personality disorder wants to be close to with those that they have comfort with, but but can be hard if they are trying new things and feeling rejected. All right, 5 seconds. All right, so the problem with Kahoot is that it does not allow you to put a full sentence. So we have to save it space as much as possible in order to help out a little bit. Okay, in order to uh, put a full sentence or as much as possible here. So it's very, very challenging to create a sentence that it for a test like. So we have to be very creative. So remember schizotypal and schizoid, they do share some things in common, right? So they all belong to cluster A, but Jesus schizotypal is the odd eccentric one, the magic thinking, this disturbance of a perception disturbance. Now, your schizoid is the one that doesn't want to see anyone, totally fine alone, indifferent to praise or criticism. Or we got 5 seconds. All right, so even again, if you didn't know anything, all you needed to look at it is order, perfection, and control. All that was in the stem of the question, right? So sometimes that can be a very powerful technique when you're stuck and you don't know the answer. Look, if you see similar words in the question. And sometimes those same similar words or synonymous will be presented. When we look at obsessive compulsive personality, it's not the same thing as obsessive compulsive disorder. This is a personality, it's a trait. They are very much like, even though they may have a good paper, they rather be late and lose 20% of the grading rather than turn it in on time, because they are so consumed with perfection, preoccupation with rules, right? Work order and things like that. If you try to be perfect in everything you do in life, life's going to be very stressful, right? It's going to be very stressful. So when we look at borderline personality disorder, on the other hand, we're talking about more of instability of mood, relationship, and self-image. We all know about antisocial personality disorder, the number one psychiatric condition or diagnosis most likely to commit crime and homicidal behavior, and histrionic. It's characterized by attention seeking and highly emotional as well. All right. That is a very clear definition for autism spectrum disorder, right? So if you picked something else by mistake, I totally get it. But if it was a true conscious answer, then there is some learning to do, and that is totally okay. Maybe you were in school, maybe you haven't been in school in a long time, but autism spectrum disorder will be on your board in many ways, okay? Many formats. So make sure you know it super well. Oppositional defiance disorder is characterized by defiant, usually I say defiant of order, of someone that is in control, usually mom, dad, the teacher, stepfather, right? And specific language impairment, right, is often a mechanism or output of the language, but usually it still has to desire to socialize, still has a desire to socialize and use nonverbal cues if necessary. But unlikely autism, they don't do eye contact. What do they have? Increased parallel play, playing along each other, but not with each other. And even at age 12, they still have parallel play. They have prolonged parallel play that is important. right. How old is Eva or Eva? She's 5. So option A requires CBT, requires high level cognitive skills. Ava is in the prime age. Is it true? No, absolutely not. She's 5. It requires high cognitive, uh, high cognitive skills at 5. She probably would not be a good candidate for CBT. So when you think of autism spectrum disorder, ABA is definitely the answer. Evidence-based structural therapy for social and behavioral skills. Now, a 5 years old may not benefit from psychodynamics therapy or psychoanalytics, right? And we're very happy that no one's going to send this little girl to ECT. So thank you for that. I appreciate that. Okay, 5 years old should not be going to ECT. Okay. All right. ABA is high yield, very, very high yield. All right. All right, we got 10 seconds. All right, this one was tricky, but remember, ID can be childhood condition as it can be an adult, right? So the only reason why I said this can be tricky was because of the age. Some of you guys may think, well, ID has to be childhood or adolescent. No, it can be adults as well, okay? But the question said something about this increasing tension and explosive behavior. It is a behavior problem, not an emotional problem. Okay. So the hallmark for IED is the outburst is completely out of proportion to the provocation, is often described as 0 to 60. And then we kind of give him the knowledge of road rage, right? Reactions where the patient completely loses controls, and then it'll be like, okay, fine, maybe it was out of control, right? And then they're like, so that is an IED in a nutshell. Very rarely, my entire life, I only seen one adult being diagnosed with IED, and it still was the wrong diagnosis. It's usually teenagers, but it can be adults. Okay? Conduct disorder. In order to be conduct disorders, it's really almost criminal activities, and to some extent, killing cats, hurting people, stealing money, right? And the question didn't have much about giving an indication that could be a borderline personality disorder. A little bit, I guess, intense anger, but didn't have much to support bipolar at all. Like 5 seconds. All right, close, right? Bupropion, great, great use for fatigue, often considered better than a, a SSRI. So that's not correct, you know. So one of the reasons why SSRI is considered the first line medication is least harmful in case of overdose, right? I'm glad no one picked TCA or MAOIs. That's a good start. All right, 2 seconds and go. All right, so we need to know the contraindications to Wellbutrin, history of seizures disorder, usually eating disorders, and if someone is really going through withdrawal, they shouldn't be on Wellbutrin at the same time, right? Now, it is prescribed often for those with nicotine dependency and they want to stop smoking. And history of seasonal affective disorder is also one of the reasons people often prescribe it. Now, insomnia, it may cause it to be worse at first, but it's not necessarily a contraindication, right? You should be watching out for because they may cause some people to lose sleep, but it's not necessarily a must contraindication. So Wellbutrin, what does it do? Lowers the seizure threshold. So Wellbutrin XL is one of the few medications specifically uh, approved for FDA to prevent depressive episodes in patients with seasonal patterns. Oh, I don't know what happened there. Let's see if we cannot make the same mistake as some of you guys did yesterday, because we talked about this in detail. This question, no. Yeah, so, the reason it is there is because yesterday a lot of people made the same mistake, right? Specifically for, 35 years old, 45, 55. it's not necessarily that we would not be concerned about increasing suicidal behavior. It's just much less common, right? Now, what is the most common side effect that everyone's concerned about that we need to educate? Sexual dysfunction, right? Sexual dysfunction. Now, if the same question was presented for a 16 years old or anyone less than 24 years old, then increasing suicidal behaviors could be the right choice. Same exact question. If you change the age, it would change the answer. Okay. That's why I say all the time we have to learn and not memorize it, because we can get the exactly same question, just change the age, and now we have a different answer. All right. Okay. So I don't know if it was a mistake or a impulse, because it says, what is your initial action? When we say initial action, we should be looking at airway, breathing, circulation, right? Which will be the vital signs. Now, if someone is manic, having pressure speech, they don't have a problem necessarily with breathing, circulation, right? So we have to be, maybe it was one of the things that you like, it must be it because it says the initial action. Anybody has a comment on that? That's what maybe why you picked.
Yeah, because yesterday we had a similar question and you said check the vital signs to make sure they're medically clear because they're already at the hospital.
Perfect. Okay. So it was nowhere near the same question.
Oh, because
It
yesterday
was
she
about
had
cutting
exhibited
ribs.
self-harm
It
because
was
she
about
had cut
cutting
herself.
ribs.
Right,
And
I
there's
got
no
it.
harm. She's not bleeding or anything, or there's no
I got
cutting
it. I got it.
herself. Yeah.
I got it.
Okay.
I'm learning. I got it.
Good, 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 good. These are the things that we kind of work through it in the question banks, and we kind of try to tease it out. I don't want nobody to be a robot and be like, it's 100%, this must be it, right? And this is why I did that question. I put the vital signs to see if we can think
How
a little bit. Just because as initial action doesn't mean it always 100% of the time we do airway, breathing, circulation. Someone is manic,
I'm
there is no
thinking,
bleeding.
I'm thinking it's someone in manic, even vitals not gonna be accurate, and it's the like he's gonna be he or she gonna be very hyper, and vitals
Exactly.
not be accurate.
Correct. It might be hyper, but unless if they're in using drugs, it wouldn't be in a dangerous mode. So what is the most important thing to do for this patient here?
Safe.
Assess for their safety, right?
Mhm.
The safety of others. Okay. Now, assess medication history. That is important, but later. And definitely coping skills, but once they are not manic, because right now they don't want to talk to you anyways, right? They're not like about talking right now, or maybe they're talking a lot, right? But whatever they want to talk about. So assessing for their welfare, right? And make sure that they are not going to hurt themselves and others. So now the question is, remember, just because having being manic does not give you the right, even though you may have the power, to force an admission, right? Unless if the patient, there is a clear indication that there are risks to themselves or others, they can still be manic as long as they understand the risk versus the benefits, right? That they may hurt themselves and so forth and so on, right? You have to make the best kind of clinical decision on the spot. It's hard. It's not easy. You know, half of the medical staff will be like, you have to admit it. And the other half like, no, you know, it's not a threat to self or others.
Even answer C says assess immediate risk. So I think that answer C itself explains itself. I meant.
Yep, absolutely.
Dr. Lopez, I have a quick question. In this case,
I can't stop it because the question went on, but we can talk about it in a second, okay?
okay.
Right. So I wanted to see the reason for this question is, can we learn from previous questions? Can we adapt? Right. So a very similar question, I think question number 1 was presented. This one was even more out there because it said psychotic features. Can lithium help with psychotic symptoms? No, right? What are the medication categories? Antipsychotics. So I wanted to play that out to see if we could get a little bit of learning as we go. Now, what happens if you give someone who's manic a antidepressant, right? It's not going to help them. Specifically, I even put a bipolar 1 just to make sure that no one's trying to make up on their mind. No, it's bipolar 2, they're depressed. No, they're manic right now. And I even put a bipolar 1. So you will make them even more manic. Okay, so we have to, is anyone confused about why not lithium? Okay. If you are, you can speak it. You know, there's no...
Olanzapine will provide a faster result.
Say it again?
Olanzapine or Zapexa will provide faster result than lithium.
My apologies. I don't...
Olanzapine or Zapexa will provide a faster result than lithium.
Much faster. But also in this specific question, it was a psychosis, right? Psychotic future. So lithium is not going to help with that either. So it's even more of the reason that we would not pick lithium. Now, there was a previous question. Someone had the question that I don't remember what it was. Now is a good time to ask.
Yes, hi. This is Samra. I did have a question for like manic patients. You were talking about admission and stuff. Wouldn't it need anyhow like 2 PCs? Like, I know this is not related to the boards. I was just kind of wondering, like, could you even admit manic patient to the hospital if they are not, you know, like if they don't agree to it? Like, would you have to have 2 doctors to sign for that?
Yes.
Okay.
Usually, yes. You know, if they are not agreeable, then you assess, and then you have somebody else come and assess, because it's a big deal. You know, psychiatric conditions alone doesn't necessarily give anyone the right to withhold someone's freedom, right? So if the patient doesn't agree, then it becomes even more a problem, right?
Okay.
So
Yeah.
now,
I was just wondering, I know it's not anything to do with boards, but I was, thought that came to my head.
it's actually a great thought because I'm surprised that I haven't seen anyone talk about or haven't seen a question like that on books, because that would have been a great question. That would have been a fantastic question, to be honest with you, because because we have to think about the patient's rights, right? Least restrictive environment,
They do.
confidentiality.
They have seen a question like that, and
Yeah.
I don't remember exactly how it was phrased, but they have it.
Okay. Yeah. I think it should be a question like that. Now, remember, lithium is the mood stabilizer of choice, is the gold standard. So, but usually it takes it more than a week to achieve therapeutic levels. And you have to do it labs and adjust it, and then you got to give it slowly. If you are going to give lithium, be aware to keep the patient for several days, and I'm sure the patient is not going to be happy, neither insurance may be paying for that. So there is a lot of roadblocks. Okay.
Sorry, I have a question. If Depakote was,
Oh, we'll go back to that one second. But yes, you can give Depakote. So yesterday we talked about why would the numbers be low for TSH, right? Because that is hyperthyroidism. So what happens, it is feedback loop where the TSH is suppressed. So therefore cuts down, therefore you see the number goes down, and that it kind of explains why hyperthyroidism is usually less than 0.5. So when you see someone with TSH level of 0.1, and then you look at T3, T4, they will have an inverse relationship, then you have a perfect picture for hyperthyroidism. And we need to know what they look like because it matters in psychiatry. So the reason why this question was here is to emphasize that we need to know 0.5 to 5 TSH labs are very important. You will see questions in which it will ask you to evaluate whether the patient is hyper or hypothyroidism, and you need to know the TSH levels. As I mentioned, 0.5 to 5. All right, we got 5 seconds. All right, so one that has hypothyroidism, everything is cold and slow, right? They feel like lethargic, depressed, hyperthyroidism, everything is hot and fast. They may have diarrhea, insomnia, heart rate is increased, eat, but gain no weight, which is completely opposed of the hypothyroidism.
Yeah.
Okay, if you give opioids for anxiety, you might lose your license. Okay, eventually. I'm glad that no one picked benzodiazepine. I'm actually surprised. But it does have a high risk for dependence, right? And shouldn't really be used for anxiety in itself. It creates a huge problem. And I'm glad that no one has prescribed antipsychotics for anxiety, uh, normal anxiety. Now, we can do antipsychotics for patients that have major depressive disorder after we tried several combination, like quetiapine can be given for major depressive disorder, but you would never do that as your first medication, right? After you have tried everything, you may be able to do a 50 milligrams of quetiapine can be helpful, specifically if they have insomnia. Now, don't do that as your first line medication, please. Okay. So whether it's generalized anxiety disorder, major depressive disorder, OCD, right? Trichotillomania, pulling hairs, SSRIs would be a great choice. Okay, and many other conditions out there, SSRIs do kind of work. All right, 3 seconds, pick your best answer and go. All right, so there was a purpose that we put a panic attack versus panic disorder, because not only is it important that you can distinguish them because of the diagnosis itself, but because of treatment specifically, right? So when you see things like panic attack is just one, right? As they become more often, it becomes a panic disorder. Well, in a panic attack, you may do propranolol, right? You may even do visceral. The board does not like benzos, but for sure, benzos probably would be the first medication to give if someone goes to the ED, right? Here's your benzo, follow up with primary care provider. That's what they do, right? I mean, it's true. They don't want to, that's your, no longer have any anxiety, right? So you're good. All right, go home. Okay, but make sure you follow up. Here's your paper. Make sure you sign in. You understood the condition. Good to go. Tomorrow, next week, follow up. Okay, not their problems per se. A primary care will solve that, or the PMHNP. Now, panic disorder, then we are going to treat them just like we would for generalized anxiety disorder, OCD, or major depressive disorder. And SSRI would be the medication of choice.
Dr. Lopez.
Yes.
Yes, hi. I have a question about the last question.
Okay.
Now, I do know you stated that, of course, like with the benzos, we don't give that to patients that have anxiety due to the risk of them being addicted to the medication. Now, we do know the SSRIs, it takes about, when I was reading some other materials, it did say about even 4 to 6 weeks. So why can't we give them some benzos for a short time, maybe like a certain amount of pills to kind of help? This is just a knowledge for like,
No,
when we stop practicing.
it's not wrong, but you have other choices. For example, you can do propranolol, right? You can do propranolol. It brings it down kind of fast too. You can do Vistaril, right? If you give like 100 milligrams of Vistaril 4 times a day, they are not going to feel anxious anymore. They're going to be sleepy. So you don't, it's not that it is correct. It's not incorrect to give benzos. It's just preferable. You have other choices that is less addictive for the board specifically. Now, the thing with benzos is they are wonderful. They'll work. They'll work really well. And that is the danger. Anything that works that well gets to be addictive, right? Anything that has a short half-life, hits it, does the job, that can be a problematic. And then again, we can be just like, well, I fixed the condition. Now, the patient is no longer anxious or having panic attacks. Yeah, you did. But now the problem goes on to somebody else. It's not incorrect, what I'm trying to say. But for the board, if you can treat it with propranolol, or if you can treat it with the Vistaril, would be a better choice. Now, panic disorder is a completely different ball game, right? So we're talking about SSRI. Does it make sense?
Yes, thank you.
Yeah, it's not wrong for sure. By the books, it's definitely not wrong, but we have to be conscious that everything we do, there is consequences too. Right? We may solve the problem now and create a bigger one for tomorrow.
Dr. Lopez, would they ever give us choices like between propranolol and hydroxyzine?
1 second. So yes, you definitely you could be giving those options. It's unlikely, um, but let me just pull it up something here.
That was one of the options on the crash course review questions, the propranolol and the Vistaril, but the patient had asthma.
Correct. So that is really not a choice, right? So here what we're trying to look is like, can you understand two concepts at once? That if it is panic attack and the patient presents with taking albuterol, and I'm going to entice you by say, hey, option A, propranolol. Hopefully we can learn two things in one question, kind of a scenario. I'm just looking something here. Hydroxyzine. One second. All right, can't find it. Okay, yeah. So I mean, gotta be very careful with propranolol and those taking asthma medication, right? So again, a panic disorder, patient must be experiencing recurrent is a disorder, unexpected panic attacks, often defined as the features of elevated from panic to panic disorder as at least 1 month of persistent worries about the future panic attack, right? So that is important. It's constantly worried, am I going to have the next panic attack, or significant maladaptive behavior, or avoiding to go out because you're afraid of. Right. So the reason why I put it in that question right from the beginning is to kind of like assess not only the knowledge, but are we pay attention? Right in the beginning, it says the person came in, John, because we're persistent defiance of behavior, right? Something along the lines. So again, even if you didn't know anything at all, you could look and say which one of the scenarios, the options below, involves oppositional defiance disorder, argumentative, blames others, defiles authority, right? So sometimes we just gotta look at the question and be like, do we see something that matches, right? And it's very important not to confuse it with conduct disorder, which is a different level, right? Killing cats, killing animals. And there was nothing to suggest generalized anxiety disorder, which, by the way, for the board, often comes with 6 months. 6 months is high yield, okay? So when you look at conduct disorder, hurting animals, physical fights, using weapons, setting fires, stealing, right? John here, he's annoying, and he's very argumentative, but he's not necessarily frying cats. Okay, he's not doing something terribly illegal. He's just annoying, but you know, physically aggressive towards others. It's more likely to be conduct disorder. All right, so I don't think it needs an explanation, right? We have the symptoms after fighting with the spouse, paralysis. Then we have something called conversion disorder, or can't convert, right? For conversion disorder, which is a true psychiatric condition. So now, if you think about it, you can think about the same question scenario for adjustment disorder, but the symptoms would be different. This would be a neurological symptom for conversion disorder. Adjustment disorder, same thing. You have a stressful event followed by mood, anxiety, or disturbance of a conduct, or a mixture of those. The same type of scenario. So it's kind of easy when you start learning the question to looking at the question by not necessarily memorizing the scenario, but understanding. It makes it a little bit clearer. All right, 10 seconds. Right. Can we find the stressful event? Yes. Lost his job. And how did he feel? Pretty anxious. Exactly like the previous question. So if we learn to deconstruct the question, then no questions is kind of hard. So we have to look at each of the diagnoses and think why this and not that, right? So this is a pretty clear case. Now, sometimes can be in disguise, such as someone was diagnosed with herpes, HPV, malaria, or whatever, went home, start crying every single day. So it doesn't necessarily jumps at you, but know that even a medical diagnosis and how you feel after can be considered an adjustment disorder. When there's an anxiety disorder, specifically generalized anxiety disorder, it's about everything. It's 2 in the morning. Where's my birth certificate? Where's my ID? I can't remember if tomorrow, I have something to eat in the morning. It's about everything. And major depressive disorder can be triggered due to stressful life events, but usually you cannot pinpoint when it started. It's usually slow onset and then could lead to depression overall. All right, same scenario, just a different flavor. Same scenario. What was the stressful event?
Death of a friend.
And how did he present after? He was rebellious. So why not then ODD? Is he defying or being against order and discipline? No, right? So that is the difference. ODD, you're looking for someone that's kind of like breaking the rules just to break the rules, but not as bad as killing cats, because then you would be upgrading to conduct disorder, right? So adjustment disorders can be depression, anxiety, or disturbance of conduct, or a mixture of those, okay? All you have to do is look, can you find a stressful event? And the question was very clear to say, after this happened, how he presented, rebellious. So it was an identifiable stressor, the death of a friend. And how did they feel after the person felt? The grief, right, or depression, but rather, in this case, acting out, rebellious. So we really have to understand, because even though those examples or questions presented today, they're pretty telling and obvious, but we need to be waiting for a higher type of questions in which may not be that obvious. Okay, but fear not, we're getting there little by little, day after day. Just keep fighting, keep practice, keep making mistakes now. Now is the time to make the mistakes. Now is the time. All right, so here we have it. So this one was pretty good. This was pretty easy to see was PTSD. Good job, everyone there. Right? So in order to be PTSD, we have to have those four things, which is intrusions, right? Avoidance. The intrusions can be the nightmares, the flashback, or intrusions of thoughts. Then the avoidance. I don't want to be near the dark alley ever again. and how we feel, the negative symptoms, the cognition, the mood, and then the hyper arousal reactivity, always on edge, right? Okay, so we talked about OCD, the obsession, and the compulsion, two different things, right? And we also mentioned that the compulsion can be a tic disorder. So we mentioned not to jump into a tic as a Tourette's, as in a modem, just because you see a tic. That can be the compulsion. What is the compulsion? It's something that we do to release the anxiety of the obsession. The obsession is driving or precedes the compulsion. And we have to do something to stop thinking about whatever. In this case here, if we say the obsession would be germs, and the compulsion is what are we going to do to release this pressure or this phobia? We're going to do the compulsion, right? We're going to wash our hands many, many times, and that way it kind of clears out. It's the action, the compulsion. The obsession is the thoughts. Very important. And then we talked about being ego-dystonic, because unlikely of obsessive compulsive personality disorder, right? OCD, they actually know that it doesn't, I know it's unreasonable that the germs are all over my hands and that I'm going to lose my job if I don't go to work because I'm washing my hands. So they know and they seek treatment, right? So while other personality disorders, they don't know they have a problem, so they don't seek help. All right, 1 minute. All right, this is kind of hard, but if you think of what is tic, it's a movement disorder. Which neurotransmitter is most likely to be associated with a movement disorder? In this instance, uncontrollable is involuntarily. It's dopamine, right? So now we know It's not just one, far from being just one neurotransmitter. It's usually really has to do with norepinephrine, dopamine, and serotonin. But if you are ever asked, what is the one neurotransmitter? Dopamine. And how are you going to remember? Think of Tourette's as being a movement disorder. And dopamine has a lot to do with movement. Okay? But it really is more than just three, right? Nothing is just like one thing. It's usually an imbalance between several neurotransmitters, okay? All right, I've got one more question. All right, good job, everyone. Yeah, we have to know the age related to schizophrenia, 18 to 25 for males, females usually 25 to 35. I'm not saying that it's impossible to be outside those age range, right? 3-4 years this way or 3-4 years this way is totally fine. But if we have to give it an age, usually beginning, late teens to beginning adulthood, all the way to 35 years old. That's the prime for a breakthrough of schizophrenia. It's very important that you remember the age for breakthrough schizophrenia. Remember what kind of difference we would see if we look at the anatomy for someone with schizophrenia through a MRI. Remember what are the four neurotransmitters involved with schizophrenia, right? There's so much that we can cover that we don't even come close to talk about it. But Caitlin, good job. All right, Lizette, good job. Well done, everyone. Well, thank you for being here, Nicole. You killed it. And TD, Tools, and the other person just in the name was too slow. Well done. Okay, folks, all of you guys, I think whether we know most of the questions or we didn't know one or we learned a lot, I think we grow every time that we come together, not only as a cohort, but as peers, as a support system. And make no mistake, climbing up the ladder is painful. It requires a lot of hours, a lot of dedication. And if you happen to be not doing so well today, don't feel discouraged. All you have to do to be on the top here is not quit. That's the only thing you have to do, I promise you, is not quit. Is not feel frustrated. Is not giving up. We can find thousands of ways of being right. I got kicked out of my own meeting. Google sometimes they'll do tricks like that. So, we can find 1,000 ways to be incorrect, but as long as we persist and insist and get up and go again, our time will come. Okay. Maybe it's not tomorrow, maybe it's not next week, and that's okay. Some of us learn differently. Now, it's been a long week. It's you know, it's been long weeks, many long weeks, really. I won't be here for very long for today because I really have to take my wife out. But before I go, I just can't help myself, right? Before I go, I just really want to reiterate a few things that we must do to pass the board. I just can't help. There is no way. All right. So remember the crash course review question bank, extremely high yield, right? So where is it? I still have some people saying, Dr. Lopez, I don't have on mine. And then I log in as them. And then they're like, yes, you do. You got to expand and contract, right? If you do the crash course review question bank, I can almost tell you, you probably get, I'm low ball 60 questions right. So there are 65 each day. This weekend, I'll try to maybe add few more, but only high yield question comes here, right? After you complete each module, you do the basic knowledge. So modules 1, 2, 3. So this week we cover module 3. So what should be your goal? Whether you are doing the question bank after you attend the live or after you do your own self-paced module in the course, is to complete the question bank. You cannot do all the modules and then try to come back here and be like, you're not going to remember, right? So you learn or practice and then you put into practice. So please, whatever you do, make sure you plan ahead of time. No way you have enough time to do it. If you need to do more, there is more questions for you to do. They're called supplemental to help you, but you don't need, unless if you feel like, oh, I want to do more question. Maybe some of you guys do. I know some of you guys do, because I get asked, can you do more questions? Can you do more questions? Yes, there is more question to do. Now, time is important, right? It's a hot commodity. The second thing that we must do and we cannot skip, so please know where is your document. It's highlighted for you 4 days or 4 crash course review documents. I had somebody that passed the board maybe like last week, and she had failed the first time, and she came to the courses. She said, I am so mad. And I was like, why are you so mad about it? You just passed. Only if I had joined your class and read these 4 documents, I would have passed. Okay? So please, you have to kind of know each line, and I'm not exaggerating. Is the reason why it's called the crash course review, right? Because only important information, extremely important, makes it to the documents. And hopefully you have a good clue why, right? Now, the last thing is, am I going to pass the board? You already know the answer. You already know it, right? The first time you take your 4 diagnostic tests, if you score 80, don't hyperventilate yourself like, oh, I don't know, it must be lucky. It's not lucky. So you have 175, 175. It's not 175. 1 or 2 might be 160. I don't remember. But generally speaking, so you have nearly what? Let's call it 150, just to make it easy math. 600 question. It's more likely that you hit the lotto than it is for you to get 80% on each task and not know your content, right? Now, it is. So show me, I would rather risk 5 numbers than to have to take 4 tasks of 150 and score 80 for each one of them, right? Now, if you took the task and you saw the answer, then, doesn't count anymore. So your goal is to get here and kind of like understand the content, love the content, it's here for you. Don't memorize answers, right? Because as we mentioned today, question about SSRI, and sexual side effects being the most concerned, the question can be suicidality if the age change. So you have to understand the content and not memorize it, because if you do, the test will be easy. So you know already if you are going to pass or not. Now, does it need to be 80%? No, it doesn't, right? I am trying to give you a buffer for feeling nervous, for maybe, you know, you didn't have a good night's sleep because you're thinking about, even though you don't have to, because you have done a lot. Think about it, doing these 1,000 questions in question bank. Then you come over here, do another 600. Then I said another 600 in the crash course review week. You have done a lot, right? The program is not necessarily easy, but it's comprehensive in order to yield the highest passing rate out there, right? There is nobody else that's spending that many hours giving you the videos and the follow-ups and answering emails. But this is where we do, because we don't want to see you feel disappointed. And everyone has a different learning curve, right? For some people, 3 weeks might be enough. For others, they may need 12 weeks. It doesn't matter. We are here and we can help you. We want to help you. But the only thing that we cannot prevent, all you have to do is continue your journey, right? And even if it's not as fast as you think the other person, we have a tendency to think that other people are always smarter than we are. Oh, for that guy or for that girl, she gets it so easy. Well, we don't know that. It may appear to be that way. Little did you know that that person's probably starting until 2 o'clock in the morning every single day. So they are not smarter than you by any means. They just haven't give up, and they may have a different type of attitude, right? So they may appear to get it so easily, but oh no, I don't start at all. I just woke up like knowing all the things, you know. It was never, we don't know what goes behind doors, right? So please remember, the 4 diagnostic tests are not negotiable. You have to take them. Then you have your 65 questions, 7 days, which maybe next week will be 8 days or 9 days. And then you have your 4 crash course review question bank. I think that seals the deal to a much higher level. So we had a student 3 days ago. She said she passed the board and she had 20 questions unanswered because she ran out of time. She still passed the board. 20 questions unanswered. I'm like, oh, what else is she's gonna tap? Dr. Lopes, I didn't answer 20 questions. I was like, oh. So far, this crash course review, we had 100% passing rate. We had somebody that did not pass, but the person only did the question bank, right? Never came to our classes. So that doesn't really count precisely. It does, but it doesn't, right? So, so far, I'm crossing my fingers. It has been a few days now, and everyone has passed 100% passing rate. But it's all credit upon yourself and the work that you do, right? It's all upon you. You're doing the right thing. Just keep at it. All right, folks. I see a lot of hands here, so I'm going to answer those 4, 5 real quick. Okay, no more. I have to go for dinner. Lynette, go ahead, please.
Okay, sorry, I had to step out real quick for the panic. And so for panic disorder, so if they already are anticipating, we don't want to give hydroxyzine every time, right? So do we give like an SSRI then for prevention of panic?
Yes. Panic disorder, SSRI. Panic attack,
Then
you can do propranolol, Vistaril, or benzo, but preferably for the board, they do not like benzo.
Got it.
So, you know, the traditional answer would be benzos, right? But
for the disorder, the SSRI to prevent.
yes.
Oh, okay.
Yes. You know, it's a longer term management with the least side effects, and it works out to be much better. Think of it, I like to think of this, I know it's completely wrong, but I like to think of this way. When you pour cement on the ground, if you have never seen it, you know, it's like this thing never is going to be hardened, but over time gets to be pretty strong. So that's what an SSRI is. It takes a while, but once it settles in, it usually does the trick.
Okay. Thank you. Enjoy
All
your
right.
day.
Yeah, absolutely. Patience. Hi. Are you there?
Lopez, yeah, I'm here. Dr.
How can I
Lopez,
help you?
I have
Yes.
a quick question, but
Sure.
I have I have my test this week. I've been with you for a while now, so I've scored 96 in all the diagnostic, and I'm doing the crash course review. So I think I'm pretty okay. I want to go and take the test next week.
Okay. Well,
Yeah.
good luck. Make sure you
Yeah.
do the crash course review question bank.
Yeah.
Trust your instinct. If you know, at some point we're going to have to face the fear, and we're
Yeah.
going to have
Yeah.
to test, right?
Yeah.
So maybe that is your time.
Yeah.
As you go, you know, it's a put your windows down. Be
Yeah.
happy that the day is here. Not be anxious. You
Thank
should
you.
be happy. The hard part is the training. The test day is
Yeah.
easier. Okay.
Thank you
All
so
righty.
much. Thank you.
My pleasure. All right, Tamara.
Hi, Dr. Lopez.
Hello.
I was confused because I'm going over my PDF that you sent when I initially purchased the crash course. So I'm finishing module 5 next week, but I'm confused about the schedule. So do I do diagnostic tests and then the crash course with the crash course questions, or like what is the?
So, usually is one module per week. So we have 5 modules, which is the regular um, modules here, right? So modules 1, 2, 3, 4, and 5, and then we have the crash course. So if you already attended the crash course review, please do not watch the videos, because that's not a waste of time. It's a good practice, but you already have attended and you have the document. So from here, you jump into the crash course review question bank, right? Which is different than the 600 questions that we send it for free for everybody. So the crash course review question bank is what you should do just before you do your diagnostic test.
Okay. So I haven't done the live crash course review. So if I have not watched the video.
Yes.
Okay.
Absolutely. I mean, it's painful because it's 20 hours, but it's absolutely needed. Absolutely needed.
Okay.
But it all depends too when you're testing, right? So the next crash course review is going to be June 13 and 14. Maybe you are testing before then. Maybe you need to watch it. Maybe you don't. Maybe you can jump into questions, do a lot of questions, and attend the crash course review live and go through the documents and then prepare to take your diagnostic test. There is no right 100% formula. Does that make sense, Tamara?
Yes. Thank you.
All right. Thank you for the question. Caitlin, you cannot ask questions. You won today, so you have no questions. Good job. Congrats. How can I help you?
Quick question, kind of similar to the previous question, but I think I asked you earlier too, but I just wanted to clarify.
Sure.
I'm testing June 22nd, so I'm planning on attending the crash course.
Yeah.
Recommend doing the diagnostic test before the crash course or after, like that week leading up to the test?
I think after for you, because it's June 22nd, so we have the crash course review 13 and 14, so you have roughly 6 more days to kind of like get them down. You should have no problem.
Okay.
I think I probably would do more practice question, more practice, maybe do all the question bank. I mean, if you're maybe like me, I would do the question banks, all of them, just because it's like, well, it's here. Might as well put in my schedule and get them done. And then maybe do one of the diagnostic tests, specifically diagnostic test 1, and then leave 3 for after the crash course review. Because even though the crash course review is 2 days live, we still can't cover everything, so not everything is going to be covered in the crash course review.
Okay. Thank
Well,
you.
good.
Great
Good
night.
job today. Good night. All right. Mrs. Imperial,
Mary, I'm sorry.
Marion.
So
Okay.
so the diagnostic, you say it's for them. Is that now I'm a little bit confused because I thought they were under the modules. I thought that
They
after
are.
oh, okay. So do
Okay.
you were
So,
Mhm.
so sorry. So after each module, you have the question bank, right? So
Mhm.
if you go, for example, if you go into the, let me see, what is this here? I'm sorry. I felt, okay. So back, 1 second. Sorry. All right. So if you go after each module is your question bank. So let's say you go to any of the modules, let's say module 3, right? And what is the last video of module 3? This one. Then now, hey, click here, go to your question bank. It pops up, and then you log in into a question bank there. Now, question bank is very different than the diagnostic test, right? Question bank is relax, you see the answers, and you adapt as you go. The diagnostic test is all at once. The diagnostic test is like your final. In the diagnostic test, you are going to find it under your modules 7, 8, 9, and 10 of the video content. The same location where you have your video content. Does that make
Okay.
sense?
Right. So after each module, we'll complete the full one. Then you want us to do the diagnostics test and then move
Yes.
on. Okay. So what if you don't do well on that particular one? Just go back and look at all the videos again and then.
No. I mean, nobody has time to look at the videos again, right? The PDF is the core. If you watch the video and you understood, now just stay in the PDF. Now, let's say now that you're like, oh, I've done everything. I don't know what to do. Well, you have 8 hours here of one-to-one, so you can watch it for free. You know, this is a very good one. I don't know. Now, a lot of people is making to this module 11. If you say, well, I have students that are not testing until August, right? A few months from now. But like, well, you have all these one-to-ones that you can watch. There is the WhatsApp group that's booming. A lot of
Yes,
good
I'm on
information.
there.
Yeah, it can cause a lot of anxiety. There is the course forum here that you can get information. There's so much going on, 24 hours, right? But
Okay.
yes,
Thank you.
did I answer your question?
Yes. Thank you so much.
Already. So last question here, so that way I can actually, well, I'll do 3 more. All right, Jamie.
Hi.
Hi.
So the crash course question, so when you add a new question, you only add it in the crash course day 7?
Correct. So that way, so that's a good question. Let's say you beat me because I leave it open. And the day that you went over there, I only had 3 questions. All you have to do is reset or retake it. And then now I am at question maybe 52 on the crash course.
Oh.
So I make it to be 65 a day. So that way you don't do it all at once. And you can always retake them. Now, the crash course review question bank, it's very important to read the rationale because in the rationale, I'll be adding things that are not necessarily related to the question, but related to the topic. Let's say the topic is about lithium, and I'll say, okay, remember about lithium interaction, remember about lithium dehydration, remember about lithium and sodium, other things. So each of those questions, not only they are high yield for the question in itself, but the rationale is covering probably 2 or 3 more questions. That's why I'm so certain that if you do the crash course review question bank, even if you don't get it right, by reading the rationale, you'll probably multiply each of those questions that will be applicable to a scenario that you might see on your test.
Okay.
Does that make sense?
Yes. And then one more question.
Sure.
So the diagnostic test. I did diagnostic test 1 yesterday. I see that it gave what you got wrong because I thought we weren't going to know what we got wrong. Is diagnostic test 2, 3, and 4 tells you what you get wrong as well?
I don't think you did diagnostic test 1.
I didn't?
No. I mean, I don't know what you did, but diagnostic test 1, are
Yeah.
you, this one right here, the baseline test? No, right?
Wait a minute. I
What
did
you,
it.
what you probably did was the question bank, right?
No, I clicked on. What did I click
You,
on? Because it
you,
says
you,
diagnostic test 1 on it.
no, this is diagnostic test 1. It doesn't give you the rationale. There is no rationale for
Well,
1 and
no,
2.
it just told me what was wrong. It didn't give a.
Right, right. I mean, you got to know what your score is, but should
Okay.
be no rationale. And I know I'm about to change it. I'm about to create the rationale because I got too much resistance. But the whole idea is that instead of giving you handed to you like I do for diagnosis 3 and 4, 1 and 2, if you've done everything correctly, you should be arriving to 1 and 2 and still have few days to learn from it, right? So going back to the PDFs and looking through the answers, and you might find something else that you didn't know that we didn't cover as a question. But oh, I forgot about duloxetine and smoking, for example, right? So we hope that by not giving you the rationale, you can go back to it. Now, we know that diagnostic 3 and 4, you are in the last few days and you're about to test, so we go ahead and give it to you, the rationale. Does that make sense?
Yes, I'm in my
But
last few days.
yes, so,
Need
you know,
to
it's
do-
just,
I need to do the other 3 tests this weekend.
yeah, just, you know, and yeah, so by the way, the system is going to go down tomorrow for about 6 hours, I think, from 11:30 to 6 p.m. For as far as the test in itself, I have no control. I don't own, you know, I don't own the system. They just told me, hey, we are going to be off from 11:30 to
The morning, okay?
oh,
How are you, Sam?
already. All right. Now, just make sure if you are going to do it tomorrow, make sure you do it early so you're not getting.
Dr. Lopez, you're muted.
Thank you. I didn't even notice. It's like having 4 tests, like 4 board certification exams, and that allows you to learn from each one of those and prepare. We don't know what we don't know usually until something happens, right? Like now I got it. I think I know it, but we don't know until we see a presentation. Like maybe I don't know as much as I thought I knew it, right? So each of those tests give you opportunity to process the information, going over everything all over, and give you a new opportunity to take a new board test. It's not the board test, but is high yield information, right? Alrighty. Okay. So Hiba.
Dr. Lopez, I just wanted to ask what time the diagnosis. You just answered my question. I think the previous person asked. Thank you.
Yes, I think I got a notice from 11:30 to 1800. They say maybe 6 hours. So just count at 6 hours, okay?
Eastern time. Okay, thank you.
Yes, I assume it's Eastern time. SK, let me make sure it's Eastern time. I don't know. Let me see. I'll get the answer right now. SK, you there?
Hi, Samra.
Samara.
So
You
I
gotta
have a
change your
question.
name because I will not remember.
I don't know why it comes like that. I don't do anything. I just log in and that's how it comes. I don't know why.
You can change it. So is Central Time, okay? So the platform will be unavailable for quiz takers and administrative. I cannot help you either. So it's unavailable to me as Central Time. So Central Time is 1 hour before Eastern, right? Just so we'll be probably 12:30 Eastern Time.
Thank you.
Okay? Already. Go ahead. What
Samra,
was
yes.
your question? Samara?
Yeah, so question and maybe a suggestion. In regards to the question bank, like after the like after every module, I only took the first diagnostic the one that you take when you start the course, and I didn't do anything else, but I do take the one after every module.
Okay.
So would you say difficulty-wise, are those much easier than diagnostics?
That's a good question. I don't know if they are much easier. I would say they are. I mean, I would say they are not. I think they're, I mean, yes, because even though, let's say we do module 3, you will see questions that doesn't belong to module 3 on here, maybe belongs to module 2, module 4, but the test is all over the place, right? It's completely 100% all over the place. So I think the test is harder because if you just did module 3, you might see 80% of what we learned cover on module 3. So I think those might be a little bit easier.
You know, I just compare those questions, and I know maybe I shouldn't, to the nursing school, to the RN question. And I'm like, those are much easier. So I kind of wonder, like, are they just made for us to learn? And I was like, the tests itself in the diagnostic, it's much harder.
Yeah, I think, you know, the foundations are much easier. Now, when you get to be the crash course review question bank, there will be, let's say, let's pick any question. They'll be usually longer, right? They will have a longer rationale most of the time. Look, how long is the rationale? Because I'm adding more things about social reciprocity, about symbolic thinking, even though it's probably not even related to the question directly, you know. It is related to autism, but I'm covering all the things about autism, parallel play, absence of friends. So I'm covering a lot on the rationale. So those rationales, so each 65 questions translate to 150 pages of Microsoft Word, right? So they're usually, and then I put a board pros for you. If you say parallel play, think autism again.
Okay.
Right.
And in regards to the, you know, the diagnostic tests, maybe suggestion, like I was subscribed to a different question bank as well, and they have the option where you can do the tests in a mode that gives you the the rationals, and then there's one. So like, if people are complaining, maybe they could have a choice to do it that way. You know, I think it's better not to know if you are studying, but you know, everybody's different.
Yeah, no, I mean, you know, if you're doing other question banks or like Pocket Prep or things like that, I don't have that kind of money to buy a $300,000 system, right? So it's kind of, can't compare. You know, these
Okay,
are
so I wasn't sure. I understand.
no, yeah.
Okay.
I wish I could. I mean, this is okay, but we're looking at the possible solution. Well, where, you know, we might just put everything together in one course. We're looking at a few things just to ease. I'm always looking, how can I ease the anxiety a little bit more for you guys? So
Gotcha. Thanks.
Alrighty.
I wasn't sure. I don't know. I was like, maybe there's an option to do that. I don't know. Thanks.
Already. There is a lot that goes behind the scene that
we don't know, right? Thank you.
All right, thank you. Right. What is your question?
Yeah, is the whole site going to be down tomorrow, or just the diagnostic test?
Just the diagnostic test, because we use 3 systems to put the course together, right? We use the question bank, the video system, and the test. It's 3 different systems.
Okay.
It's only the test, but the question bank should be up, you know, and the course, the video course should be up.
Perfect. All right. Thank you.
Already. Last question.
Cecile.
Hi.
Cecile. It's okay. Yes, Dr. Lopez. So my question is, the questions that you emailed before the crash course, is it the same every time, or is it different one?
It is the same every time, because that's only meant for the people that say, well, I don't want to buy the question bank. Well, you don't have to. I'll give it to you something to practice, right? You don't have to buy it. But this is different, right? This is very different. This is the premium content.
So I was just asking, so you know, to see if I need to go back to those previous ones and do them, or if I just do this one that was recently, I'll be good.
Yeah, no, this one was recent. It's the same one. If you don't have the time, do this. Don't do the 600 questions. even though a lot of people say, hey man, the 600 questions is super good, super high yield, I see a lot of information, may not be exactly word per word on your board, but you still learn from the content. All right, folks, so it's a Memorial Day weekend coming up soon, next week, right? So no class next week. Make sure that you still have the videos, you still have the question bank, and then I'll see you guys the following week, okay? You guys have a good night, and I wish you absolutely amazing tests. If you are testing soon, don't fear, be thankful. You know, I had somebody says, Dr. Lopes, I'm going to test tomorrow and I already passed. I say, well, that's the spirit. And she did pass. She had no problems. But you did a lot of work. The task will not be super challenging. Now, fight for every question, because you might get the first 25 questions. Be emotionally prepared to be like, am I taking the right test? You know, and then then the next 50 questions, you get everyone right, right? So with that being said, fight for every question. Have a great night, everyone. Thank you for being here with us today. Good night, everyone. Bye. All right, go ahead, Sarah. Do you have a question or no? Is that quick? Nope. All right. Good night, everyone.